All right, everybody, I think we're going to get started. So our presenter today is going to be Dr. Ruben Valenzuela. So a little bit about Ruben. He was born and raised in the Philippines. He finished his neurology training at the University of Illinois. He's currently a fellow here in Neuro ophthalmology, and he's actually one of my favorite fellows because of his patience and his willingness to teach. But after he's done here, he's actually going to go and do a second fellowship in multiple sclerosis, after which he has a job lined up at the University of Illinois in the neurology department. So without further ado, here's Dr. Valenzuela.
Okay. So I'm going to do a short lecture on the neuro-ophthalmic manifestations of sarcoidosis. And so we'll start with a case. So I have a 40-year-old Caucasian man who we saw in consultation in September because of blurred vision in the left eye. And so he was previously healthy. In August, he awoke with painless loss of vision in the left eye. And he described his vision as almost like a frosted glass appearance with like a fishnet over his left eye. And it was constant. And he described it was associated with intermittent episodes of transient visual obscuration that would happen at least 4 to 5 times per day. Although he denies any eye pain, he said that his left eye feels tired all the time. So he denies headache. He has no shortness of breath, no cough. He has very mild fatigue. And he has this rash in his anal area that's been going on for the last 3 years. And he has a rash in his left knee that has not been evaluated by his primary care physician or a dermatologist. And so on examination, his visual acuity was 20/15 in the right eye and 20/50 minus 1 in the left. His pupils were symmetric with a 0.9 log unit relative afferent pupillary defect in the left. His visual fields and extraocular motilities are normal. His anterior segment examination is normal. Specifically, he has no cells in the anterior chamber. He has a 2 millimeter left proptosis. On dilated examination, his right optic nerve is normal, but he has a +3 disc swelling in the left eye and some retinal striae in the left eye. His neurologic and physical examination, were otherwise unremarkable, except for this small rash in his left knee. So his MRI actually showed enhancement proximal to the left optic nerve, and also there's evidence of obstruction of the CSF flow in the optic nerve sheath distal to the lesion. And you'll see there's minimal extension of the lesion into the optic canal. The right optic nerve seemed normal, and there's no evidence of tumor or metastasis elsewhere in the brain. And when you look at the coronal section, you'll see that the left optic nerve is also actually enlarged. Yes, sir?
So when you say impaired flow of CSF, you're talking
About the
sheathing on one side.
correct. So my impression is if you have increased flow of CSF and increased pressure, the fluid would just go through the sides of the nerve sheath from pressure itself. And then we also requested the CT of the orbit to check for any abnormal calcification, and we didn't find any abnormal calcification in the CT of the orbit. And we also requested the chest X-ray specifically to look for any pulmonary infiltrates or bihilar lymphadenopathies, but the chest X-ray was normal. And so in summary, we have a 40-year-old Caucasian man with a painless loss of vision in the left eye in the setting of a left optic neuropathy and severe swelling actually of the left optic nerve. He had an abnormal MRI, and we gave him a trial of steroids, and he was responsive to steroids. The visual acuity actually improved in the left, and there was also some improvement of the left proptosis. And so for this particular patient, we considered the following differential diagnosis. So we considered meningioma, glioma, lymphoma, infectious and any inflammatory condition, and autoimmune and demyelinating disease. Although the CT of the orbit did not show any abnormal calcification, we still considered meningioma in the differential diagnosis because only 30 to 40% of patients with meningioma would show abnormal calcification in the CT scan. And so what do you want to do next for this patient? Any suggestions? labs, imaging, observe.
Start with a lab workup and maybe even, depending on your suspicion, also consider doing an LP as well.
Yeah, so we talked about a number of differential diagnoses. So what specific lab do you want to get for this patient?
Yeah, CBC, CMP, inflammatory marker, stuff, CRP, FDA, RPR for
Very good. So all those were requested. So because of the high suspicion for infection and inflammatory process, we got a CBC and ESR. They were both normal. We also did an extensive infectious workup. So we did a quantiferin TB, a test for syphilis, a viral panel. They were all negative. Liver enzymes were all within normal. Serum angiotensin converting enzyme was within normal. I think it was 9. And then the only thing that came out positive was an elevated serum lysozyme, 27 nanograms per mil. I think the normal is, about 17. We also got a serum aquaporin 4 to rule out neuromyelitis optica. He had the lumbar puncture and the CSF profile was normal. He had no cells. Sugar and protein were both within normal. And so we did not really have, based on the labs and the presentation of the patient, we really did not have a definitive diagnosis. So we considered, there was a discussion about getting an orbital biopsy, but because of the risk to his vision, we were kind of thinking of getting a less invasive procedure. So we ended up getting a biopsy of his skin lesion. So skin punch biopsy of the left knee. Remember, in his physical examination, there's this skin rash in his left knee. So we got a skin punch biopsy that showed granuloma. And still with the granuloma, you have to consider other inflammatory or infectious process, but the non-cascading nature of the lesion made sarcoidosis a primary diagnosis. And so this patient was diagnosed with ocular sarcoidosis without pulmonary involvement. And so sarcoidosis was first described by Dr. Jonathan Hutchinson. He's a dermatologist, and he described this diffuse raised red lesions in one of his patients, but he did not really use any term for this lesion. In 1888, Dr. Ernest Besnier coined the term lupus perineo to describe this raised diffuse skin lesions. And then in 1909, a Danish ophthalmologist named Dr. I forgot his name, Christensen, described a triad of symptoms consisting of fever, parotitis, and uveitis. And from then on, they were describing a condition called sarcoidosis. But in 1915, Dr. Schoeman actually emphasized that sarcoidosis is a systemic condition. And so he made a lot of research on this disease, and because of all his work on describing this condition, pathologists describe this calcification and these protein deposits in the Langhans giant cells as Schoeman or asteroid bodies. In 1937, uveroparotid fever was first described, and then the first international conference on sarcoidosis was held in London. And interestingly, we had the first convention on sarcoidosis in Washington, D.C. in 1961. And so sarcoidosis usually occurs in the third or fourth decades of life, and the prevalence is estimated at around 10 to 40 per 100,000. But the incidence is actually higher in African Americans, at least 10 to 17 times higher. And in Caucasians, around 15 to 20 per 100,000. It's sporadic and there's no gender predominance, although ocular sarcoidosis is more commonly seen in women. And then the etiology is unknown, so it's largely a diagnosis of exclusion. A lot of studies were done on genetic and environmental factors, but it revealed really little about sarcoidosis. But currently there are studies on association between HLA-DRB1 and Mycobacterium tuberculosis DNA in relation to sarcoidosis. So histologically, they would present with non-cascading granulomas in the affected tissue with some asteroid and Schoeman bodies. And so half of the patients with sarcoidosis would be asymptomatic, and the rest would present with different symptoms. And the most common would be respiratory symptoms. So some patients would present with cough, shortness of breath, and some would have skin lesions, as my patient. And skin lesions would vary from, having like almost like an erythema nodosum, lupus perineal, scars or plaques. And then lacrimal and salivary gland involvement is relatively common. And then I'm just going to point out that ocular sarcoidosis is very common presentation. It's found in 30 to 50% of patients with sarcoidosis. And in fact, it's more common than neurosarcoidosis, around 10 to 15%. And in fact, some literatures reported only 5% of neurosarcoidosis. 90% of patients with sarcoidosis would have pulmonary involvement. And so a very important test would be getting a chest X-ray or chest CT. And there's a pulmonary staging for sarcoidosis if there's pulmonary involvement, of course. And so the staging are based on 4 different stages. So stage 1 would be bihilar lymphadenopathies on chest X-ray. And 67% of these patients with bihilar lymphadenopathies would have spontaneous resolution of symptoms within 1 to 2 years. And then stage 2 are patients who present with reticulonodular infiltrates. Around 46% of patients would have a spontaneous resolution of symptoms within 1 to 2 years. And then stage 3 are patients with pulmonary infiltrates. And unfortunately, less than 10%, around 10% would have resolution of symptoms in 2 years. And then, of course, the worst would be patients presenting with fibrocystic changes and bullous changes in the chest X-ray. As you can see in this table, so sarcoidosis would be basically systemic manifestations of, different organs can be involved. If you note, the cardiac involvement is very rare, at least 5 or less than 5%, but it's the most clinically challenging and the most fatal involvement in sarcoidosis. And so, again, I would mention that it's very common. Ocular involvement is 30 to 50% versus 10 to 50% in neurosarcoidosis. So what are the neuro-ophthalmic manifestations of sarcoidosis? So you can have anterior uveitis, and in fact, it's the most common ophthalmic manifestation of ocular sarcoidosis. So 40 to 70% of patients would present with anterior uveitis, and 80% of the time it's bilateral involvement. And typically they would present with acute iritis or iridocyclitis. And then posterior uveitis would be seen in 14 to 20% of patients. And with posterior uveitis, it's very common to have cystoid macular edema. And then the other presentation would be orbital sarcoid. You can have involvement of the optic nerve, the optic chiasm, or the posterior chiasmal visual pathway. And oculomotor dysfunction and pupillary dysfunction have been reported in the literature, but not very common. And so the signs in anterior uveitis can be, mutton fat, creatic precipitates. You have Kepi nodules. You have Bosaka nodules. You have anterior chamber or ciliary body inflammation. And so this is an example of your mutton fat creatic precipitate. So these are inflammatory cells that are found in the corneal endothelium, and most of the time it's associated with granulomatous inflammation, and it's highly suggestive of sarcoidosis. And then you can have Kepi nodules that are usually seen along the pupillary margins, and it's when you have Kepi nodules, it can be a nidus for posterior synechiae, and there's a risk for developing, cataract, glaucoma, and band keratopathy. And then you can also find Bosaka nodules like closer to the limbus, these brown arrows, and then mutton fat creatic precipitates are this, whitish nodules right here in the corneal endothelium. And then in posterior uveitis, the signs would be from inflammation, obviously inflammation of your vitreous, your retina, and your choroid. And then the common signs would be your candle wax drippings. You can have branched retinal vein occlusions. You can have neovascularization and hemorrhage. You can have vasculitis. You can have chorioretinal granulomas. So this patient presented with choroidal vasculitis, as evidenced by the white subretinal spots. So this particular patient presented with cells in the anterior chamber in the vitreous. And so another sign in posterior uveitis would be candle wax drippings. So this would be your whitish and sometimes yellowish white, waxy retinal precipitates that are found along the retinal veins, usually in the inferior equatorial retina and sometimes in the posterior poles of your retina. And some literature suggests that 20 to 40% of patients with sarcoidosis would present with candle wax drippings. And histopathologically, candle wax drippings are actually represent periphlebitis and chorioretinal granuloma. So sometimes the candle wax drippings are called granulomatous periphlebitis. And then you can, this patient obviously had a branch retinal vein occlusion from ocular sarcoidosis. You see this segmental interretinal hemorrhage. And then you can also have retinal vascular sheathing, as you can see in this colored fundus photo in this angiogram. And then patients can have chorioretinal granulomas. This can be associated with your candle wax drippings as well. So these are whitish lesions, and they appear in clusters. So whitish lesions are usually associated with more active disease, and then more chronic disease usually present with like grayish appearance of the lesions with sharp margins. So they could be chronic or cicatricial lesions. And so they can also have retinal macroaneurysms, as you can see in this fundus photo, and the intermediate and late stage of your fluorescein angiogram. But I think what's interesting is when they took an ICGA of this patient, it showed hypofluorescent areas that actually they said that were associated with occult granulomas. And so I think ICGA is very important, especially in patients that present with very minimal ocular signs, and you want to prove that there's bilateral involvement. So ICGA is a good test. And so, although not specific, you can see neovascularization and hemorrhage with ocular sarcoidosis. And so, orbital sarcoid, the most common manifestation would be involvement of your lacrimal glands. And sometimes patients can also have tumors that appear in the eyelid, so they can have eyelid mass. And then the signs and symptoms can mimic an orbital tumor, so they can have optic neuropathy, they can have diplopia, exophthalmos and proptosis, and signs of dry eyes. And this is an axial MRI showing bilateral lacrimal gland involvement in a patient with lacrimal sarcoidosis. So symmetric involvement of the lacrimal glands have been reported to be highly suggestive of ocular sarcoidosis, but you have to rule out other causes of bilateral lacrimal gland involvement. And you have to make sure that you rule out lymphoma, leukemia, and infection. And one literature suggests that a good way of differentiating sarcoid from lymphoma in your imaging is getting a DWI, diffusion weighted imaging, and ADC. And apparently, a lymphoma would have lower DWI and ADC compared to your compared to your sarcoidosis. And then there are certain imaging findings that can help you say whether this is lacrimal involvement in sarcoid. So usually they describe lacrimal involvement as diffuse, smooth, homogeneous involvement and almost symmetric involvement of the lacrimal glands. And just additional information, lacrimal glands thickness normally measure around 4 millimeters. In this particular patient is at full thickness, it's around 11 millimeters. So this patient was diagnosed with lacrimal gland sarcoidosis. So another example would be sarcoidosis involving the lower lid margins. Optic nerve involvement is very rare, but when they do happen, they can present with varying degrees of visual field defect and relative afferent pupillary defect. And they can present with papilledema, they can present with anterior or posterior optic neuropathy, optic atrophy, or disc elevation. And so this particular patient has this small nodule in the disc that resulted in disc elevation and kind of dramatic elevation of the disc in someone with sarcoid papillitis. Optic chiasm involvement, again, is a rare presentation in sarcoidosis, but when they happen, it's very difficult to differentiate from your pituitary tumor because they present similarly with patients with a pituitary microadenoma or macroadenoma for that purpose. So they can have diabetes insipidus, they can have amenorrhea, galactorrhea, hypogonadism, or bitemporal hemianopia. So this T1 post-contrast sagittal and coronal section shows enhancement of the optic chiasm. So this was a pediatric patient who was initially misdiagnosed with optic chiasm glioma and ended up having optic chiasm sarcoidosis. He responded really well with steroids. And the involvement of the posterior chiasmal visual pathway can be symptomatic based on 3 different mechanisms. So they can have compressive effect, they can infiltrate, and they can have vascular changes, and sometimes you can have stroke-like lesions or stroke-like symptoms from angiitis and from thrombosis. And then you can have oculomotor dysfunction. Basically, the most common would be isolated 6-nerve function. Involvement of the 3rd nerve is not very common. And if you have a gaze palsy, make sure you rule out supranuclear gaze palsy from neurosarcoidosis. So pupillary dysfunction, they can present differently as severe as loss of vision or some change, just minor changes in your pupil. For instance, you can have parasympathetic denervation and you can have atonic pupil. Sympathetic denervation, you can have Horner syndrome, and you can also have Argyll-Robertson pupil. And sometimes patients would come to you with Bell's palsy because cranial facial nerve is the most common cranial nerve involved in sarcoidosis. And the second most common is your optic nerve. However, of course, patient can present with multiple cranial neuropathies. And so because ocular sarcoidosis is very common, so the International Workshop on Ocular Sarcoidosis actually developed a diagnostic criteria for ocular sarcoidosis. And so it's universally accepted that to have a definitive diagnosis, you have a positive biopsy. But some patients would not agree to have intraocular biopsy because of risk to their vision. So the International Workshop on Sarcoidosis developed diagnostic criteria that may or may not involve biopsy findings based on 7 ocular signs and 5 laboratory tests. Okay, so the 7 ocular signs are the signs that we discussed in anterior uveitis. So patients can have mutton fat, creatic precipitates, Kepi or Busaka nodules, trabecular meshwork nodules. They can have string of pearls, vitreous opacities. They can have multiple chorioretinal lesions. You can have candle wax drippings, optic disc nodules, and very important would be bilateral involvement with sarcoidosis. And then the 5 laboratory tests would be very important to check for TB, check for a serum angiotensin converting enzyme and or a serum lysozyme, check for chest x-ray. If chest x-ray is negative, do a chest CT, and then check for liver enzymes. And so this is not part of the diagnostic criteria, but I just want to make sure that when you work up a patient, you rule out all the masquerades or the mimickers of sarcoidosis. So make sure you rule out TB, ocular TB, lymphoma, viral infections. I forgot to add here syphilis as well. You need to check those. Autoimmune and demyelinating disease, Vogt-Koyenaga-Harada syndrome, not very common, but sometimes can present like sarcoidosis. And so serum angiotensin converting enzyme alone has 73% sensitivity and 83% specificity. It's a very good test to monitor disease activity. So higher ACE levels are usually associated with more active disease. And then 58 to 60% of biopsy-proven cases of elevated angiotensin converting enzymes. But when I was doing my research on this topic, it's kind of interesting to note that they're saying that angiotensin converting enzyme is not really very useful in 2 sets of populations. So children can have elevated angiotensin converting enzyme above the normal values. And then watch out for hypertensive patients on ACE inhibitors and patients on lisinopril. So patients on ACE inhibitors can have undetectable levels of angiotensin converting enzymes despite having raging sarcoidosis. And so for this 2 population of patients, the solution, they said, is get a serum lysozyme. Although it's not as sensitive or as specific as your serum ACE, it has 60% sensitivity and 70% specificity. In our patient, he was not on any ACE inhibitor. ACE unfortunately was negative within normal, but the lysozyme was elevated. And then since granulomas can form in the liver, you want to make sure that you check your liver enzymes. So check for alkaline phosphatase, check for AST and ALT. To be considered significant, your alkaline phosphatase should be at least 3 times above the normal value, and your AST and ALT should be twice above the normal value. And so, again, check for TB, very important. So I would prefer you do a quantiferin TB gold. So, for example, never ever do a tuberculin skin test in a patient like me who came from a third world, who has a BCG, because there will be a lot of, maybe difficulty in interpretation depending on who's reading your skin test. So quantiferin TB gold is simple, it's easy, and it's very easy to interpret. So go with quantiferin TB gold. And then chest x-ray, at least 50% of patients would have pulmonary involvement. So always get a chest x-ray. If chest x-ray is negative, go ahead and get your CT of the chest. And then, that's it. And then based on the 7 ocular signs and 5 tests, there are 4 levels of diagnostic certainty based on the International Workshop on Sarcoidosis. So you have a definite sarcoidosis if it's biopsy proven, whether it's a skin biopsy, a transbronchial lung biopsy, a lacrimal gland biopsy, and then you consider the ocular symptoms. So it's a presumed sarcoidosis if you have bilateral bihilar adenopathies and ocular signs. If for any reason you don't have the bihilar adenopathies, you need 3 signs and 2 positive lab tests. And for possible, you need 4 signs, 4 ocular signs, and 2 lab tests. So this is a diagram I got from the International Workshop on Sarcoidosis. So you will see these are two different approaches. So the dotted lines are in countries where sarcoidosis has a very high incidence. So they start with a very invasive and aggressive procedure. So they do transbronchial lung biopsy. And depending on the result, they go with the less invasive procedures to diagnose the patient. So I think the way to go is being practical and being non-invasive. So if you have ocular signs and symptoms, you do your chest x-ray. And if the patient has bihilar adenopathies, then a presumed diagnosis is made. Then if this is negative, then do your other tests. And then depending on how the test looks like, then you decide on whether you want to do a biopsy. And the biopsy would be any of the following. You can do skin, you can do a lymph node, salivary and lacrimal gland biopsy, and then conjunctival and transbronchial lung biopsy. It's a blind procedure, so you can have false negative results depending on which area you biopsy. But it's interesting to know that bronchoalveolar lavage is actually one of the diagnostic criteria used by the Japanese Society of Sarcoidosis, and so they stain the fluid and they look at the pathology, and in addition they look at the T lymphocytes, the T cell count, and an elevated CD4 and CD8 level is actually suggestive of sarcoidosis. And so I'm going to go back to the ICGA because I think some clinics underuse ICGA in diagnosing sarcoidosis. So for a patient who has signs of anterior uveitis, signs and symptoms of anterior uveitis, but very limited ocular signs of sarcoidosis, ICGA is a very good test to show the clinical picture and the diagnosis of the patient because it confirms the bilaterality of the disease, and then it also detects ocular choroidal lesions. And then they mentioned 4 ICGA signs for sarcoidosis, although I think it's non-specific. So you look at hypofluorescent dark spots, and then there's fussiness of the large choroidal vessels, and then there's late diffuse choroidal hyperfluorescence, and then they said very common, you see hyperfluorescent pinpoints in patients with ocular sarcoidosis. And so management of this, yes? Both anterior and posterior. So for management, majority of the patients, 75% would require symptomatic treatment with or without steroids. But then for patients with widespread disease, corticosteroids is the mainstay of treatment. So one literature I reviewed mentioned using methylprednisolone at 20 milligrams per kilogram per day for 3 to 5 days, followed by prednisone taper. And then for patients who are unresponsive to steroids or who cannot tolerate steroids, you can consider steroid-sparing agents. So the most studied drug, non-steroid-sparing agent for sarcoid is methotrexate. So there's a lot of pulmonary and hepatic toxicity around, I would say, 10 to 20%. So they recommend, of course, using folic acid when you treat patients with methotrexate. And then another drug would be azathioprine. So those bone marrow suppression with azathioprine. So one of the complications would be malignancy. But the most common side effect would be thrombocytopenia and elevated liver enzymes. There's some report of success in using mycophenolate with uveal sarcoidosis, neurosarcoidosis, or pulmonary sarcoidosis. But I think what's commonly used now as a replacement for methotrexate is leflunomide because of the purported lower pulmonary and hepatic toxicity. And so, in general, the patients can have, the disease can remit spontaneously, but in some patients, you can have exacerbations and remissions. And the prognosis is less favorable in African Americans. And with cardiac involvement, it's really a bad prognosis. For patients who have chronic HORS, the following can happen. They can have risk for lung cancer. They can have cancer in other areas that are affected by the sarcoidosis. There's a risk for lymphoma, and there's a risk for lymphoproliferative disorder like a non-Hodgkin's lymphoma. And so for this particular patient, so this patient received methylprednisolone and prednisone taper. His vision actually improved from 2050 to 2020, and the proptosis actually, improved as well. So he's being followed by pulmonology and rheumatology, and so far he's been happy. I didn't ask about the anal lesion, but he's happy with all what's going on with his life right now. Overall, much improved. Those are my references. Thank you.
So what's amazing to me about this disease is the lecture you gave is not substantially different than one would have been given 40 years ago. It's incredible. As common as the disease, we have not come up with a new one. It's just, don't you think, Al? It just blows my mind. There's clearly something. I mean, an altered immune system, but when you're getting granulomas, there's got to be a nidus of something that's causing that to happen. And the fact that we have not been able to determine that to date just, to me, is
So
fascinating.
actually, I agree with you. There's a lot of interesting work going on right now that reports kind of a subclinical tuberculosis exposure that is responsible for these granulomas. So people there is this kind of overlap. You mentioned clinary testing. There are patients that test clinary positive in patients that have definitive sarcoidosis. So you're looking at that. But
So they're thinking this may be some type of a subclinical exposure, and then it kicks off an autoimmune that continues on its own.
the patients actually have tuberculous protein that is causing granulomas infection, but it may be the inoculum or the exposure is less than pulmonary tuberculosis. And some of the evidence, I mean, it's circumstantial, but sarcoidosis has been described. There's some kind of a myeloplasmin sometimes that occurs.
Right.
So one thought is people are exposed to the same pathogen. So maybe it's tuberculous protein. There's also then, of course, kind of environmental exposures like silica and brucellosis, things like that are always excluded in diagnosis of pulmonary disease. But I think that's the leading kind of thought in terms of etiology, and then it sets up this kind of granulomas infection.
You've got that whole group of people who, I've got a good friend in whom he had some nasolacrimal duct obstruction. They biopsied it, came out non-caseating granuloma. Said, oh, macro looks like it's sarcoid. 30 years later, nothing's ever happened. something like this somewhere that never really had, I mean, he never had anything in his chest CT or anything else. So I think there's a lot of people out there that quietly something that would look like sarcoid that never develops.
That's
It's a fascinating disease.
Yeah, that would be unusual, and your case is unusual because 90% of the patients will have some type of disease, and it's the organ system that's predominantly involved that kind of drives treatment. So we have many patients, for example, that will have probable sarcoidosis that biopsy not proven bilateral lymphadenopathy, and no other biopsiable site. And so those patients probably have that, and their pulmonary function is fine, but they have ocular disease. So we will treat them as probable sarcoidosis for ocular disease. On the other hand, I saw a patient, for example, yesterday, it was day before yesterday, with cardiac sarcoidosis and no pulmonary involvement, and that was biopsy proven, actually. So that organ system would, he's on treatment for sure.
And I was just going to add, if the patient is followed by a pulmonologist, sort of the treatment may be driven also by the person who, or the specialty that's treating the patient. And the pulmonologist will use medications that are completely colchicine, which is completely ineffective for ocular and CNS involvement.
So there are also some other treatment options. Methotrexate is probably the most commonly used immunomodulatory medication. There's actually good evidence for its effectiveness in pulmonary disease and concomitant ocular disease. And the pulmonary involvement with side effects, methotrexate is pretty low. I mean, it's kind of a hypersensitivity reaction that occurs, but and it's used as a steroid-sparing agent. There are biological for patients that fail those medications. There's good evidence of biological medications, particularly infliximab, more recently with rituximab and insulin resistance. The other differential, apropos last week's grand round, in terms of just ocular disease, in terms of is lymphoma in the eye and birdshot retrochoroidopathy. Those would be the two major ocular differential diagnostic entities that I would think about. So when I see a patient with disease in the back of the eye that have those white dots back there, and sarcoidosis and birdshot are kind of a major differential. HLA, H29 is helpful. ICG, I think your pitch for ICGA is important in diseases that in which the choroid is involved and the retina. So the retina and the choroid are involved in both birdshot and the sarcoid, and ICGA may show choroidal involvement that is not cut. It's actually quite risky.
Just referencing your comment on idiopathic and malignancy, that data is somewhat confounded by the fact that inflammatory disease can increase the risk of lymphoproliferative malignancy. And that was studied in isolated ocular disease based on the site data in John Kempton. Found that there's actually no increased risk of any malignancy that comes from metabolite. The ones that I'm worried about are the alkylating agents. There's a trend towards increased malignancy in biology. Certainly not in comparison.
Thank you.
If you're pretty suspicious for sarcoid, why not just go right to a chest CT compared to an X-ray? I think one study said about 30% of chest X-rays are negative, or CTs pick it up. So is that a better way to go?
I mean, it depends on your history, on your clinical examination. If your physical examination and your history is highly suggestive that the patient may have pulmonary involvement, then I would go with a cheaper test, would be doing a chest X-ray. Because if you find, bihilar lymphadenopathies, you don't need to, do a more expensive test like a chest CT. But in patient who does not have like real clear pulmonary symptoms, then maybe you can consider going straight ahead with chest CT. But I recommend, and the IWAS diagnostic criteria recommend getting a chest X-ray first.
I would agree with that. I think it's a better screening test. I mean, it's much less expensive. You don't want to screen everybody with a CT chest, with a CT of the chest. And I think it's useful, in a patient still have signs that are really highly suggestive of sarcoidosis, and it may increase your diagnostic sensitivity against CT tests. And I'm sorry, one other comment. I think that one of the great things about this case is that you made the diagnosis by skin biopsy.
Yeah.
So I think that rather than going directly to the lung
Yeah.
or to the eye or to the brain, I mean,
It's a lot harder to biopsy those than it is.
yeah, and patients are a little less willing anyway. But I think that the signs are often there, and look for extra pulmonary signs for sarcoidosis because it can establish the diagnosis.
Mhm.
A lot of people ask about conjunctival biopsy. We'll get referrals for patients with sarcoidosis, do a conjunctival biopsy, but blind biopsies are usually not very useful. If the patient has a nodule, then it can be increased in diagnostic sensitivity.
So when you're doing a formal presentation, it always makes it look like you totally went the right way. But the question in this guy's case was, did he have a lymphomatous invasion of his nerve, or a meningioma, or something else? And nothing was really looking like sarcoid until I went down to radiology and reviewed the case, and Ann Osborne happened to be there. And in her inimitable way, she basically said, "Oh, that's sarcoid." So then I was just chatting with the patient, as one does. He was up in Idaho. I was just chatting. Do you have any rashes at all? Any rashes? I've asked him like 10 times already. Then he finally fessed up to this anal rash. It just didn't bring up in clinic.
That's serious. That's exactly what happened.
He just didn't want to talk about it. So then I said, okay, well, you're going to derm. And dermatology, they were going for the anal rash butt biopsy. And then they said, anything else? And he said, oh, I do have this little teeny bump on my knee that kind of went away with the steroids and then came back. And they biopsied that too. And because the anal rash didn't give us anything, it was that little bump on his knee that he said that there hadn't been a trauma. And it was the world's tiniest little bump. And so they biopsied and there it was. So, it sounds more structured when you're presenting it than it actually was. So, yay for dermatology, actually taking down all clothes.
Which is a great lesson. It's amazing on these tough diagnoses. Once you figure it out, it's easy. But
Yeah.
trying to move along, I could imagine if you hadn't had a positive biopsy, you'd still be scratching.
The next thing was the biopsy of his nerve, which is really tough to do in 2020. Very, very challenging.
Very scary.
In the epidemiology, you said the predominance in African Americans, but in Utah, there's quite a bit of sarcoidosis because the other major population you see sarcoidosis in the Scandinavian population.
True. So you made that comment. So I'm not sure whether they mentioned something about HLA-BR1, and they're looking at it as in association with sarcoidosis. So I don't know if that specific population has a genetic predisposition for sarcoidosis.
Very good. Thank you.
Thank you. Thank you, sir.